but it excluded many others, and within the people that it included, it hierarchized. Now, within the system, how did the hospital set prices? How did the hospital determine how much each treatment and each service cost? So I'm going to distinguish between three periods, each of them dominated by a different logic or method of pricing. And my argument is that each of these methods was very tightly linked to this grand moral vision of Ford that Ford had about the American society. In the first period, the hospital priced care by the level of work and effort that was invested in providing it. In the second period, the hospital priced care in order to balance the hospital's books. And in the third period, the hospital priced care based on what it took as the market price for healthcare. Let me get into each of those. So first, pricing by effort. In its first 2 decades, the Ford hospital priced care by how much effort was invested in providing that medical care. So for example, sorry about how it's an archival document and the quality is not very good, but trust me. This is a document from 1919. The hospital priced care on a scale of 1 to $5. It's the care that is being priced here is a regular standard doctor's office visit, a scale of 1 to $5, depending on, quote, the time, difficulty, and amount of service rendered. Okay, so this is basically a pricing technique that draws on the labor theory of value, right? The value of things depends on how much labor was invested in them. Here you can see a later charge list that I date to the 1940s that follows the same logic. So in the 1940s, it's a longer list, and the hospital knew to do many more things then, so the chart list became really long. But the logic is similar, okay? For each procedure, there are 3 columns, okay? Each representing a different level of labor intensity, and the price of the procedure is higher when the labor is more intensive. Quite interestingly, under this pricing logic, insured patients paid more than uninsured patients. If you had insurance, you paid more than if you didn't have insurance. Why? Because treating uninsured patients meant putting an extra effort and time into filling out their forms. So you bill for that, right? What were the moral logics embedded in this pricing system? So first, as I mentioned, price equality among people. The hospital's chief of medicine wrote that prices were determined by the character of the undertaking and not based on a patient's income. The sense of equality, of course, as opposed to equity, was taken directly from the liberal view of market societies. At least formally, the hospital was blind to who its patients were: rich and poor, workers and property owners, women and men, black and white, had to pay the same price for the same types of treatment. And so prices were impersonal, and in principle, they were only dependent upon the labor invested in the services. Second, Ford wanted the prices to be affordable. Of course, not affordable to everybody in Detroit, but affordable to the Fordist citizenry, meaning those $5 a day salaried workers, members of the wealthy working class that his factory was trying to create. Third, and I think most interestingly, Ford considered pricing care by effort as a way to better the citizenry's moral character. A moral person, by Ford's view, needed to be self-sufficient and independent. And for that, you need to pay for everything you get and not receive anything as charity. So the hospital wanted to educate patients to pay for the care that they received. In an internal memo that I found, the hospital's all-powerful chief administrator wrote, "The public generally should be educated to pay for their hospital care the same as any other obligation." With a few minor exceptions, charity was absent from the Ford hospital. Ford vehemently opposed it on principle grounds. It was basically making a Malthusian argument, declaring that charity coddles people into a state of expectant, childlike helplessness, instead of training for self-reliance and self-sufficiency. And so charging prices according to the effort put into providing treatment was not only a fiscal act, but also a moral act. If the hospital's original goal was restoring people to good health and citizenship, it did not only do so by curing their disease and ailments, but also by charging them a full price, which would better their character and make them autonomous, self-reliant, and independent. But pursuing this third moral principle, educating the public to be self-sufficient and not rely on charity, turned out to be pretty difficult in practice, because throughout the period, the hospital was consistently in deficit. Every year, Henry Ford used money from his personal fortune in order to cover the hospital's losses. Now, the risk of stating the obvious, Ford had money. He had a lot of money. And during that period, he made more and more and more money by the year. So his problem with covering the hospital's deficit was not financial, right? It was moral. The purpose of the hospital, as far as he was concerned, was to foster a self-sufficient American who would pay for her or his own care. Milton Friedman, right? But if the hospital that provided this care ran on a deficit and needed charity in order to provide this care, then the hospital patient would indirectly benefit from charity, right? And this idea really, really bothers Ford. And he therefore demanded that balancing the hospital books would be made a priority. And beginning in the late 1930s, we can see how this demand changed the logic of how the hospital priced care. Prices were no longer determined by the effort invested in treating. Now they were determined at the level that would balance the hospital's budget and make it break even. Because only at this price level would care at the Ford Hospital count as non-charity. How does this transition look in practice? So take one moment, sort of getting you in the ground into the day-to-day operations of the hospital. What does it mean to people, for people, when this is how care is being priced? November 1938, okay? The hospital administrator writes to the Division of Medicine that in September, the inpatient activity shows a loss of $872, and outpatient activity shows a loss of $1,400.84. What should they do in order to offset the losses? So the administrator writes that the department should increase its output, i.e. work more, right? Serve more patients. He writes, it would have been necessary for your division to have rendered 257 more inpatient department days service and 637 more outpatient visits. Okay? You need to work more, admit more patients, serve more patients, so you balance the books. But look at how the chief of medicine responds. Okay? He requests that instead of working more, the hospital will update the price of a medical visit and increase it from $3 to $3.50 or $3.75. Okay? Now remember, the year is 1938. Okay? This is still the Great Depression. Focusing on the hospital's budgetary needs necessarily meant deprioritizing inclusion. And I have evidence that the administration was aware that some of the hospital's patients were being priced out, yet it continued raising the prices, not out of ignorance or lack of awareness, but out of commitment to fulfilling Ford's vision of a hospital without charity. It was fixated on eliminating any shred of patronage from the hospital's budget, even at the cost of excluding some of the patient population that Ford purported to make self-sufficient citizens. The citizenry of Ford's moral economy shrunk as the hospital worked to establish this economy. In the late 50s, we can see that the Henry Ford Hospital was moving from pricing care in order to balance its books to pricing care according to quote-unquote market prices. So let me first get at the context of this transition and then try to explain what pricing care by market prices meant. So we can see several developments that occurred around the 1950s and 60s in the US, which precipitated this transition. First, medical technologies advanced. And when medical technologies advance, the cost of care goes up, right? In tandem, the number of people with health insurance in the country rose significantly. And in the mid-1960s, the first two national health insurance programs, Medicare and Medicaid, were passed. So insurers, both private insurers and public insurers, became major payers and major actors in this realm. And in this context, pricing ceased to be something that the hospital did in an internal process, i.e. looked at its accounts and decided how to price care, and began being something that happens in an interaction between the hospital and the insurance company. In other words, pricing transformed from something that happens within the organization to something that happens between different organizations. How did it look exactly? So first, beginning the 50s, you start seeing the Henry Ford Hospital comparing the prices that it charged to the prices that other hospitals in Detroit charged for the same services. So for example, this is a document from 1952 showing that Henry Ford's charges for hospital beds were within the range that other hospitals charged, other hospitals in the city charged, which meant that the Henry Ford hospital, as far as the administration was concerned, was charging the right price. Okay? Just to be clear about why this seemingly mundane document is important, we cannot find any similar comparison earlier. Okay? The Henry Ford Hospital used to price care based on its own calculations of its cost, effort, account balance, not based on what other hospitals charged. So beginning the 50s, there is a transition in the social construction of what is the right or what is the correct price. The correct price was the price in the market, not the price in your own account books. Second, prices were the outcome of interactions and negotiations between the hospital and insurance companies. By the early 50s, about 70% of the fees that Michigan hospitals collected were from insurance companies and government support, and only 30% were from self-paying patients. And here too, the price that insurance companies paid came to represent the true price of care. To take one example, I found a letter that the cardiorespiratory division's physician in charge wrote to the hospital superintendent, in which she argued that the division staff have felt for some time that the routine charge for new electrocardiograms should be $10. Have felt for some time that this should be the charge. Where did the feeling come from, right? Where did the gestalt exactly come from? So the feeling came from the fact that this is what a large insurance company, the Michigan Medical Service, which later on became Blue Cross of Michigan, this is what they were paying. And if this is what the price that the insurance company is paying, then this is the right price, right? And we should increase our price. So if in the 1920s, the hospital had its own price and insurance companies were asked to pay it, by the 50s, insurance companies were paying a certain price and the hospital adjusted what it conceived of as the right price to the prices that they offered. And then a last method of pricing that I found during this period, which I'm not going to elaborate on much for lack of time, is the proliferation of various formulae to calculate prices. This is a formula from the Veteran Affairs Administration, standard form number 1, and we're in post-World War II years, so the Veteran Administration is a major payer. There were other formulae used by the polio foundations and other foundations and payers. So the hospital set many of its prices according to various formulae that were used to calculate what other organizations would pay, what in economic sociology we call market devices that the hospital uses in order to calculate the correct price. So to summarize, I'm describing a historical move in 3 acts. Act 1, 1910s to 1930s. The Henry Ford Hospital priced care by the effort invested in providing it. It did so as a carrier of a moral agenda, making the citizenry pay for the hospital care it receives and making it independent of charity care, better its moral character. 1930s to 50s, the hospital moved to pricing care at levels that allowed it to break even. This too was driven by a moral agenda. The hospital, just like the citizenry, needed to be financially independent so that the care that it provided to people did not have a charity component. And post-1950s, the hospital lost its status as a price maker and became a price taker. It took the price of care from the market, specifically from other organizations such as insurance companies and public insurers. And with this loss of jurisdiction over prices, the hospital also lost its ability to pursue a moral agenda through pricing. Conclusion. So I began by talking about how American hospitals price care today, a way which is widely criticized, that is universally seen as anywhere between arbitrary and opportunistic, and in any event, immoral and unjust. I suggested that we should adopt a sociology of critique approach, not just criticize how hospitals price care, but also reflect on the foundations, the grounds of the critique that we direct at how hospitals price care. Not just say this way is wrong and immoral, but also ask what makes a price moral in our minds. Two major critiques that we find today are that hospital prices are inconsistent and opaque. But I pointed out that opacity and inconsistency are quite common in market life. In fact, we can think of cases where charging different prices to different people is a moral expectation, a moral requirement. And still, it is clear that in the US today, people see these two qualities of pricing, opacity and inconsistency, as highly problematic. My argument is that those critiques are directed at hospitals because their way of pricing deviates from the idealized model of how that we usually look at markets through. I analyzed the Henry Ford Hospital in Detroit and its way of pricing as a paradigmatic case. It's a hospital that a century ago priced care in a way that addressed the critiques that we are hearing today. It instituted standard and transparent prices along the model of the free, perfect, and democratic market. Now, when we look at this model applied in reality, namely, when we look empirically at how the Ford Hospital priced care during its first 50 years of existence, we see several things. First, we see that there was a significant period in which the hospital did display standard and transparent prices, so-called perfect market prices. But these prices did not emerge from the intersection between supply and demand. These standard prices were determined by an executive corporate policy. One charismatic and very eccentric figure, Henry Ford, if you will, the Elon Musk of the early 20th century, who had the power to run a very extreme experiment that went everything you found in the actual hospital market at the time. But during the 50s, the hospital lost this ability. The prices started to be determined by what we can characterize as an actual market, interactions between insurance companies, the hospital, and other hospitals in the area. We had real market prices, but at the same time, they were very far from what people generally see as idealized market prices, i.e. standard and transparent retail prices. In this sense, the real healthcare market turned out to create non-perfect market prices. Second, we see that pricing care in a standard, transparent way also embodies a moral vision, which Ford sought to implement as part of his general endeavor to redesign the American working class. The moral view embodies much power within it. Ford saw his hospital as a place where healthcare will be a commodity that working people would buy. And his standard hospital price was meant to transform workers into ideal capitalist subjects, people who are self-reliant, responsible, and autonomous. Pricing care the way Ford did was his way of educating workers, forging them as people that Ford deemed virtuous and in a way governed them. The critiques of American hospital prices that we find today are not aimed directly at patients, right? Or working class people who are patients. These critiques target hospitals and the healthcare system in general. We people accuse hospitals for overcharging, for not being transparent, and for not presenting standard prices. But these critiques still make the perfect market model, they take the perfect market model as the alternative to the current system. As the argument goes, hospitals should display standard prices to the patients that they treat so patients can compare the prices and make informed choices. What the case of the Henry Ford Hospital reveals is that these critiques nevertheless lay out a set of moral expectations from patients. Henry Ford embraced standard prices because he wanted patients to be self-reliant and free of charity. When American critics today advocate for making hospital prices transparent and standard, they embrace an expectation of a similar self-reliance, that patients will act as market actors, that they will compare prices, that they will negotiate with hospitals, that they will make the perfect market hospital market a reality, which is a rather far-fetched expectation when you consider how disempowering being a hospital patient can be. And therefore, criticizing by using the perfect market model as grounds for the critique also means reproducing and spreading the moral vision that this market model engenders. When critiques of American hospitals today are largely limited to the fact that their prices are inconsistent and that their prices are opaque, and when it is limited to arguing that hospital markets should be designed like standard retail markets, that we should be able to buy hospital care in the same way that we go grocery shopping, okay? We're not only risking overlooking many other injustices, we also find ourselves unwittingly promoting an economic order that first puts quite a bit of responsibility on the shoulders of patients, and second, has never sustained itself as anything more than a chimera in the phantasmatic world that Henry Ford and his likes have aspired to create. Thank you.
Okay, thank you so much. That was fascinating. I don't know if anybody has questions. I could kick us off while those of you are taking in. That was a lot to cover, so you guys can kind of mull it over a bit, and I'll kick us off. I have so many comments. It's comments and questions. I'll just do a couple. One is with the Ford Hospital. I think it's really interesting that it's a really unique case, and I believe that it's a unique case in 1914. But I wonder if it's useful to think about like the Kaiser model, which was another kind of industry-owned hospital, also had physicians on salary, also had physicians outraged by the same type of practice. And there were other kind of industry-owned hospitals that creeped up. And so I don't really know what my question is except to say that there was a broader pattern, I think, than just this that was happening. And I wonder if that's something. So that's my first question. And then my second question is more in the later period in the 1950s. I want to push back a little bit on whether it was the market determining the prices, in the following sense, that these were nonprofit voluntary hospitals, and they were very much trying to figure out what determined the prices. But they were a coalition working together as the American Hospital Association and all their member hospitals across the country, trying to figure out how we could set prices and how we can convince the American public that the prices are right. And so I think it's sort of the same argument that you're making, but in the final conclusion of what the prices are, but very different. I mean, they strongly argued that they were nonprofit voluntary hospitals and they were more democratic than government, right? Like they weren't arguing that they were private institutions operating in a market. I think they were pretty clear they were not that. And so I just wonder how that changes the story a little bit. And also the Blue Cross Blue Shield example, the insurance, that's confusing to me because they emerged from the hospitals, from the nonprofit hospitals, right? So it's like, yes, this external actor, supposedly external actor, Blue Cross Blue Shield, is determining the prices, but Blue Cross Blue Shield was owned by the hospitals, right? So like, how external really is that? So
Yeah.
I'll stop there. Sorry.
No, that's fantastic. A lot to think about. Okay, we'll have to talk about some of it later too.
Yes.
You know, but about the Kaiser model, it's a real interesting juxtaposition. I'll have to talk to you more about it. Look, I mean, the two other questions about the 1950s and whether calling hospitals at the time nonprofit actors that were trying to set collectively prices that would be legitimate, whether this is a market. I agree, and in this sense, I do think that the Ford Hospital was a very weird and exceptional endeavor, exactly because he was, you know, the parallel to Elon Musk, I think, is in place. He was a very extreme free market liberal, believing in free market ideology, and he had the social power to try to create a certain free market ideal type as a pet project, as an experiment in his city. So when I talk about the market, I am thinking about his hospital in particular. I agree with you that this is not a representative case. It's not a case that represents the American healthcare system in general, definitely not the American hospital field, if we don't want to say market, at the time. I do think that when we ask the sociology of critique question of why do we think about lack of opacity and about lack of standardization in prices, today, I think that looking at this case is informative because he was thinking in the way that we are thinking, or politicians are thinking today. Even in our nihilistic Congress, when you see a bipartisan initiative that passes around hospital pricing, it's usually about opacity, solving opacity, creating transparency, and standardizing or trying to create a certain market mechanism for prices. So I think that these people ultimately are playing by the Henry Ford playbook, despite the fact that his playbook was completely disconnected from how the market looked like. So I completely agree with you empirically. I just have a theoretical justification for why we need to look at him. Yeah.
As insurance penetrated the markets, starting in the 40s and then continuing on, for the first couple of decades, it was dominated by an indemnity form of insurance where insurance paid a set amount if a certain thing happened. They'd pay X dollars per day for inpatient care and a fixed amount for surgeries of different sorts. It only later on, starting mostly in the mid-60s, it was really when it began to move towards paying reasonable charges. So in the earlier days, when the insurance companies were setting an amount that different sorts of care were worth, did that have an influence on what the hospital decided to charge?
Can you repeat the last question? Sorry.
So if insurance would pay, $20 a day for inpatient care and, $30 for abdominal surgery and whatever, when there were fixed fees of that sort that were what the insurance companies were willing to pay, as opposed to the insurance company paying something based on charges. Did the fees that the insurance companies were willing to pay have an influence on what the hospitals were deciding to charge?
Yeah, so It's a good question. I'll need to look. Um, my the hospital. I'll need to look. I mean, it's worth going back and looking at specific interactions. But the hospital at the time, yeah, I mean, there were negotiations with insurance companies. It's not that the hospital just accepted passively insurance companies' fees, whatever the insurance company wanted to pay. There were certain negotiations that eventually led to setting a certain price, but the insurance company had quite a bit. It sort of had its fees, and they were quite solid benchmarks that the hospital had to work with. Not unlike today. Usually, you see the Medicare fees serving as a benchmark for private insurance companies. Usually, you look at contracts between hospital and insurance companies, so it's Medicare plus 20%, right, or Medicare plus 10%. It was something similar to that. Okay, I'm not sure if I'm answering the question, but yeah.
Since I don't know the answer, I don't know.
Yeah.
Hello?
Yeah.
Yes. I have perhaps a more philosophical question. You really emphasize the need for useful citizenship in Henry Ford's thinking, and this idea of what a citizen is. And in today's culture, I think there's a whole lot of consumerism. So in many cases, is a patient being a good consumer of pharmaceuticals, of hospitals, of clinic practices, of maybe the foods that send them there? And do you see a link from that time to now? Has it changed significantly? Or do you think this is ever part and parcel of perhaps what Henry Ford thought? Or is it just an outgrowth that we didn't see coming, much as has occurred even in social media today, outgrowths that we didn't think about and didn't consider?
Yeah. It's a fantastic question. First, what I mean by citizenship, I mean citizenship for me, the way I think about it sociologically. I mean, I don't think about having a passport, right? It's a certain concept that assumes inclusion and exclusion from a certain group, and the inclusion also implies various claims that a person who is included can make. Okay, so citizenship gives you certain claims or rights to certain claims, right? And in the case of Henry Ford, there's also the moral element that in order to be a citizen, you are expected to have certain virtues that he is trying to foster, and this is how the exclusionary process also from his citizenship works. Whether we can see it today, it's a great question. I think that to a great extent the story of this chapter is a story of the rise and fall of Ford's citizenship, that he's a person who imagined the working class as a class that could potentially be wealthy, okay, that will that families could survive on a single salary, could have a car, could have a house, could send kids to college, could live in the suburbs, right, and could have health care. And this is the corporate order that dominated the U.S. for much of the 20th century and no longer exists. The American corporation has fallen. Jerry Davis was here, right? The American corporation has fallen, and we no longer see this type of citizenship. Whether other newer types of citizenship are rising, I mean, we can debate that, but I don't have a clear off-the-cuff answer. Yeah.
Hi, I have a question about. Well, it's brewing, but it started as a question about the sort of qualities of the perfect market, and I was thinking about another critique that I see fairly often, which is just that the prices are too freaking high, And I was thinking about sort of statements by private physicians of varying degrees of commercial intent in the early 20th century about this idea that the patient's gratitude is highest just after they've received treatment. And so you should try to build them as soon as possible. But their understanding of the value of the treatment decreases with proportion to the time after they've received it. Yeah. And so this question of the price with relation to the value that it embodies maybe, and where that fits into the idea of the perfect market. And the reason I'm asking is because it seems to me that that is something that people have long acknowledged doesn't really fit into a quality of healthcare that doesn't fit into the perfect market, which is that it's really hard to value something when your life might be at stake. Or, it's a problem with consumerism in medicine that, like Nancy Tomes has pointed out. So I'm wondering about that quality of, the ideal market or this aspect of price that seems to kind of be more openly acknowledged to present a problem for healthcare, which is that the relationship between price and perceived value or experienced value might really radically diverge.
Yeah, no, it's a very good question. All good questions. Yeah, no, I've been thinking a lot about this relationship between price and the value of medical care, and I think that most of the writing is going in this direction to sort of decide whether prices are not just they're illegitimate because they're too high, right? And I agree with you that this is a very common critique of the legitimacy of pricing in healthcare. And maybe something can be written about it. The thing is, I was sort of focusing on these two issues with the recognition, with the acknowledgement that prices are too high in healthcare. And I think that, yeah, you're right. Everybody would agree on that. That's another consensus that I didn't mention. Whenever, you need to come up with a justification for how do you know that the price is too high. And that's a very, very difficult argument to make. Mainly, in part because, life is priceless. The US doesn't have any type of rationing mechanism that is applied on a global scale, right? The Medicare statute determines that Medicare would cover anything that is useful and necessary. It doesn't determine what is useful and what is necessary, or effective and necessary. Effective is, the famous two clinical trials criterion. But necessary, we don't really have a good sense of what is necessary or what is cost effective. So I think it's much harder to make arguments in that realm. Ultimately, when I looked at basically all of the congressional hearings, reports, and discussions on hospital prices, ultimately these discussions and they agreed that we need to lower hospital prices, but ultimately all of the mechanisms that they were thinking about have always boiled down to market mechanisms, to increasing transparency, to displaying prices, and that's why I went in this direction. Yeah.
Yeah, that was fantastic. I think we're out of time. So thank you so much. It was really wonderful.
Thank you. Yeah. Thanks very much.